Hello, and welcome to another episode of Focus on Hope. Our guest today is Dr. Miel.
Good
Hi, Dr.
morning.
Miel.
Good morning. It's nice to be here. Yes.
Nice to have you here.
Yes,
You're an oncologist.
correct.
What is an oncologist? What does it mean?
An oncologist is a cancer doctor. So, someone who takes care of cancer patients, deals with different types of cancers or malignancies. There are different types of oncologists. So, there are radiation oncologists who give radiation therapy, surgical oncologists who do surgery, remove tumors,
Yes.
medical oncologists like me that take care of patients in general, kind of serve as their primary provider for cancer and administer treatments such as chemotherapy.
Yeah.
So that would be a medical oncologist. That would be me.
Okay. What's a typical work week for you?
Well, it gets busy. I actually go to two different clinics. One is in Cottonwood, and the other one is in Prescott Valley. The one in Cottonwood is open from Monday to Wednesday. The one in Prescott Valley is open 5 days a week, but I only go there Thursdays and Fridays. So I work a full 5 day week. It gets pretty busy. I've on occasion seen patients before 8 in the morning and sometimes after 5 p.m. Yeah, it is hectic, but I love what I do, so I enjoy what I'm doing.
How does hematology fit into oncology?
Okay, so good question. Hematology is a branch of medicine that deals with blood disorders. So things like anemia or low red cell counts, thrombocytopenia, low platelets, polycythemia vera, increased red cells. That's hematology. But hematology also has cancers, okay, that fall under it, such as leukemia and lymphoma. Hence, medical oncologists get to take care of patients with hematologic or blood related malignancies or neoplasms.
Yeah.
Yeah.
In your line of work, you deal with a lot of end of life
Correct.
concerns.
Yes, because I mean, a lot of patients at some point during their illness do progress. And at some point during their treatment, they decide that, further treatment is not what they want. They would rather be just doing what's called best supportive care. So at that point, we talk about end of life care. Talk about hospice. Best supportive care refers to care where you're really just making the patient as comfortable as possible. You're not doing any aggressive measures such as chemotherapy and surgery. It's more about managing pain, for example, keeping the patient comfortable without doing any aggressive treatment. So, yes, I do deal with that. I discuss that with patients. When they transition to hospice, then their care is transferred to a hospice doctor and they go under hospice care.
Okay.
So at that point, my care stops and they are transitioned full time to hospice.
So hospice is like the last stop?
Well, some people think of it that way. I think of it as just a different way by which a patient is cared for. It's a decision that they make for themselves when they go to hospice. They decide that it's not about longevity at that point, but more about quality of life. Not trying to be aggressive about their therapy, but focusing more on making themselves comfortable, possibly during the last days of their life.
Yeah. What do you like about your job?
Well, my patients, I think, and I mean, they are really a source of inspiration for me. I know that sounds very trite when you say that, but they really are. These are people, most of my patients anyway, who undergo treatment for cancer are quite ill, but they somehow manage to have a very positive and optimistic view about life. And that's very rewarding for me. Oncology itself is also a very dynamic field. I'm sure you've read in the papers constantly there are new things coming up, new treatments, new researches, and I'm part of that. I get to be part of that, and I think that's what makes the field very exciting and interesting for me. It's not stagnant, it's forever growing.
Yeah.
So, yeah, those two things.
Wow.
Yes.
Anything you dislike about your job?
Well, the work hours can be tough. I mean, there are people in my group who are able to take a day off from work. I mean, I used to have Wednesdays off, but because I go to two different clinics, I've decided to work full time, 5 days a week. I really don't mind that, but there are days when you wish you have more time to do other things outside of work. Aside from that, I enjoy what I do. I love what I do, and I'm grateful that I am able to do this. So,
Now you're new to Cottonwood, aren't you?
not really. I mean, I've been here for over 4 years now. I live in Sedona. I see patients in Cottonwood and Prescott Valley. I enjoy the drive. Oh, driving might be one of the things I don't enjoy because I have on Thursdays and Fridays I have to make that hour-long trip back and forth, to work. No, I mean, I've been here over 4 years. Love the area.
Now, what are some misconceptions that people have about doctors?
Well, you'll have to ask yourself that. No, but I think, let's see. It might be that some of the things that we recommend might not be necessary. I'm always I'm an advocate for screening, cancer screening. And I think some patients think that's not really necessary or they try to avoid it because they're afraid they'll end up having cancer. I think that's a misconception.
What is cancer screening?
When you have a patient undergo a procedure that looks for tumors or cancer. So an example would be a colonoscopy.
Okay.
So a colonoscopy is a procedure where you have a scope inserted through the patient's rectum and up the colon, the bowels, to look for colon cancer. So that's screening for colon cancer. Okay. Testing for PSA, prostate-specific antigen, is a screening test for prostate cancer. Now there's data to show that screening patients who are chronic and heavy smokers has shown improvement in survival. So now we screen patients who have a heavy smoking history with a low-dose spiral chest CT. So these are tests or procedures that look for cancer early on. So you screen patients so that if they're ever diagnosed, the cancer is caught early on and not later when a patient might have symptoms already. When you screen someone, they don't have symptoms yet necessarily. So a
Okay.
mammogram, for example, tests or screens patients for breast cancer.
Yes.
So at that point, they may not have cancer, and that's the whole point. You want to make sure there's no cancer, and if there is a tumor that is noted, you've hopefully found it early enough that you can still do something, say surgery, and not require other treatments like radiation therapy or chemotherapy.
Okay. Now, what are the different stages of cancer?
Well, in general, there are 4 different stages.
Okay.
So in general, we're talking about in solid tumors, for example. Stage 1 is when it's a small tumor. There are no lymph nodes that are affected. Lymph nodes are things that you find in the region of the tumor.
Okay.
And these are the first areas that the cancer would go to. Okay. Stage 2 would be maybe a bigger tumor, and there might be some lymph node involvement. Stage 3 is you've got a much bigger tumor and definitely lymph node involvement. And stage 4 is when the cancer has already spread beyond where it came from and now involves other organs. So if, for example, we're talking about colon cancer, because I've been talking about it. In stage 1, the tumor is just in the colon, in the bowel.
Okay.
In stage 2, it might just be a tumor that's a little bit more advanced. It's encroaching into the deeper aspect of the bowel, but it's not involving lymph nodes yet. Stage 3 is when the tumor is now involving lymph nodes around the area of the colon. And stage 4 is when it's already spread beyond the bowel and now involves other organs such as the liver, the lung, or bone. So stages 1 to 3 in general might still be curative. Stage 4, you could still treat, but for the most part, those are not easy to cure. And by cure, I'm talking about having the tumor disappear completely and not ever come back. So that is why screening is important. If there is a screening offered for a certain type of cancer, it's important to catch it early, because if you have it caught at an earlier stage, you could potentially have curative treatment. Whereas if it's stage 4, the treatment would be different. It would be more to improve symptoms and prevent progression of disease and improve survival, but it may not necessarily affect a cure.
Wow.
So that's the importance
Best
of
to get to screening.
exactly.
You
So
suggest screening for all your patients? Or
I encourage it with everyone.
with everyone?
Yes.
Yeah. You say you administer chemotherapy at
Yes.
your...
At my clinics. So chemotherapy is a form of treatment for cancer where the therapy or the drug is given systemically. It goes through the whole body, okay, as opposed to surgery where you're removing something at a specific location, and as opposed to radiation therapy or radiation treatment where you are radiating or giving radiation to a specific area of the body. So chemotherapy is systemic, and for the most part, it is given outpatient or in the outpatient setting. Most chemotherapy regimens are not given in the hospital. They don't need to be. They're given to ambulatory patients, patients who
People
are
are walking,
walking
yeah.
and able to go about with their day-to-day activity. It's given in clinic for the most part. They go home after the chemotherapy. Sometimes they go home with chemotherapy running through them through a pump, but it is an outpatient treatment for the most part.
Now, what's the difference between chemotherapy and hormone therapy?
Well, chemotherapy is treatment that uses drugs such as adriamycin or doxorubicin, rituximab. These are agents that are given through the vein or intravenously.
Okay.
Hormonal therapy is more specific to preventing the production or activity of hormones. So in breast cancer, hormonal therapy would refer to things like tamoxifen and letrozole or Femara. These are for the most part taken orally. There's also hormonal therapy that might be given through an injection, such as Faslodex for breast cancer. And so there is that difference.
Do you do that? Do you do that at your
Office also. The oral pills are taken by patients at home.
Yes.
So those are things that they take on a day-to-day basis. Hormonal therapy for prostate cancer would be an injection of, say, Lupron, given monthly or every 3 months, depending. But that's different from chemotherapy. Hormonal therapy does not necessarily make you lose your hair. Chemotherapy, as most patients, that's their perception of chemotherapy, is the one that could make you lose your hair and have vomiting or nausea.
Yeah.
So there is that difference.
That's a concern of patients, isn't it?
Yes, hair loss is pretty much a big concern for women, but most patients actually, think that the hair loss is temporary and the hair grows back once chemotherapy is completed. Yes, and there are things now that women use, such as hair prosthesis or wigs, or sometimes they just wear very pretty scarves, and they don't worry so much about the hair loss.
Yeah. What are some of the after effects? When a person is going through chemotherapy,
Right.
they have after effects.
There are side effects or what are called adverse effects, just like with any medication. So if you read up side effects of, say, Tylenol, there could be a list that's this long.
Yes.
The same with chemotherapy. The more common ones that patients are familiar with are nausea, vomiting, mouth sores, hair loss, fatigue, decreased blood counts. Other side effects could be things like numbness and tingling of the hands and feet, fatigue, bloody diarrhea, mental status changes, what's called chemo brain can happen. These are things that we discuss fully with patients before they are started on chemotherapy. They are given information on the potential side effects of the drugs that they're on, and there are so many ways that you can help ameliorate or alleviate symptoms, and there are also ways to prevent symptoms. So, for example, when you give chemotherapy to a patient in clinic, prior to actually giving the actual chemotherapy, you give what are called pre-medications, things that would help offset nausea and vomiting and diarrhea or rash. You give those, and then you also prescribe medications to patients that they have at home to help them when they have side effects at home. So they have medications to help prevent vomiting and diarrhea and mouth sores.
Now, should a person change their diet?
I encourage patients to stick to a healthy diet. They don't necessarily have to really change anything, but I do tell them to avoid things that are not healthy to begin with. You know, you want to be as healthy as possible with your diet. You eat more poultry and fish, more baked or broiled food as opposed to food that is fried. I still encourage patients to eat fruits and vegetables. I don't really think the diet has to completely change for a patient to stay healthy during chemotherapy.
What are some of the other lifestyle changes?
Well, that's a good question, and this is something I encourage patients all the time to do, and that is to maintain an active lifestyle. Exercise has been found to have a positive effect on breast cancer patients undergoing therapy, and it just makes sense. If you're healthier, if you have an active and healthy lifestyle, you're a healthier person overall, and you're able to undergo treatment and its side effects better than someone who's not quite as healthy or who's probably more sedentary. I encourage exercise. You know, even walking for 20 minutes a day is better than just staying at home. Yeah, and I have patients who are very, very mindful about keeping an active lifestyle. So they go to the gym even during chemotherapy. I have patients who are still, who are still active and who do that. I have patients who do yoga or kayaking. I mean, I encourage it. So.
I hear that cancer loves sugar.
Well, you don't want to be eating or ingesting a lot of what you call complex carbohydrates. You want to avoid things like ice cream and pastries. But I still tell patients everything in moderation is acceptable. So you're not. I mean, if there's something that you really want to eat at a particular point in time and it's a treat for you, then by all means, I mean, you can enjoy that. But it's really sticking to a healthy diet that I would like for them to adhere to. Yeah.
Now, is cancer preventable?
Yes.
It is?
Yes. I mean, if you avoid things like smoking, we know smoking is very much or has a high correlation with certain types of cancers like lung cancer, pancreatic cancer, bladder cancer. If you avoid smoking, you're hopefully making yourself, healthier and decreasing your risk of having these malignancies. Alcohol, too heavy of alcohol consumption can cause liver damage, which down the road can cause cirrhosis and potentially liver cancer. So yes, there are things that you can do to prevent cancer. Some things will just happen, no matter how healthy you are, okay? But there are things that you can do to make yourself as healthy as possible and hopefully avoid developing any kind of malignancy. Like I've always said, adhering to a healthy lifestyle always helps. So if you're not smoking, you're being active, I think you increase your chance of being not just cancer-free, but free of coronary artery disease and lung disease. The other diseases, diabetes, for example, can be prevented by keeping your weight low. People who have type 2 diabetes can help control their diabetes by losing weight, for example. So I think overall, being a healthy person avoids the risk of having different types of illnesses, not just cancer. It may be repetitive, but I would really like for people to be open-minded about cancer screening. I think there's misperception that if you're screened for cancer, you'll end up having cancer. But I think there are times that people are found to have cancer during a screening test. And I think in a way that's good that it's caught early. So
yes.
I keep pushing or I keep encouraging patients to get screened because it really eases your mind once the screening test is done that you don't have something,
yes.
right? And if there is something that's found, it's hopefully detected at an early stage when you could potentially still cure the malignancy. And, you had asked also about, what I would like to encourage, and that is I would like people to support research. I mean, let the policymakers know that we do need research funding to be continued, because it's through research that we find out new treatments, new and better treatments for different types of malignancies. There are still so many cancers out there where we don't have a cure, but hopefully with research and over time, we will find better treatments. In melanoma, for example, years ago, there wasn't much in the way of treatment for melanoma. In the past few years, new treatments have come up that have significantly improved outcome for melanoma patients. So there are now things like vaccines for melanoma, programmed death one treatment, anti-programmed death one treatment, pills that melanoma patients can take that would hopefully improve their outcome. So it's through research that we come up with these new medications.
Wow.
Yes.
Yes.
Polycythemia vera, there's new treatment now too that was recently FDA approved for patients who don't respond well to Hydrea. There's now an option for them. It's called Jakafi or ruxolitinib. But it's through research that we find out these things. So I would encourage that. And definitely adhering to a healthy lifestyle, having or practicing good health habits, avoiding things that would be deleterious to your health, sticking to a healthy diet, being active. I don't think I can stress that enough.
Yeah.
Yes.
Yes. Well, I want to thank you for coming on the show.
And thank you for inviting me.
Anything else you'd like to say?
No, I think that's it. Have a good Sunday to the viewers.
Yeah.
Yes.
Well, thank you very much for coming on the show.
Happy to be here.
Yes.
Yes.
Well, thank you for watching. And this has been very exciting. Thank you for joining us, and I hope to see you next week on Focus on Hope.